Okay, I think we're slowing down on entrance, so we'll probably have a few others join us, but welcome everyone. Happy Wednesday. We're in the middle of the week. We're getting there. I know we were just talking about how busy this week has become so quickly. So I appreciate all of you joining in, tuning in, and being as present as possible. I see some at home, some in the office, it looks like. So we are also having that conversation about being a mixed work-life balance right now and mixed boundaries. So again, we appreciate each of you logging in. Today we have Dr. Kramer, Michael Kramer, joining us. And I think as similar as me, we've not done the training course in person before. So he's tuning in. This is the second year he's joined us, and he's fantastic and incredibly experienced in his training. And we will both experience hopefully next year, maybe together in person for the first time, a training course. So we're all in this together, and we're just grateful that all of our faculty are able to deliver this virtually. So a couple of things, there was a homework assignment, and then all of the materials look to be uploaded to Teams, and then evaluations, as always, will be coming out with the recordings. Again, if you have any questions, it looks like everyone's having great access to the Teams and navigating that. Feel free to chat amongst each other, create groups, meetings, network. For those that are the 4 in Ohio, however it works, connect and collaborate and grow your network. And then feel free to reach out to the faculty. There's the office hours. Those are 15-minute bite-sized office hours. And then as well, if you have specific interest or projects, reach out via email. Their inboxes are open. So I just wanted to plug that as well. And I will give it over to Dr. Kramer.
Great. Thank you so much, Ashley. Good to see you all. Good to meet you. I've been present with you for most of the sessions, but this is the first time I get to talk to you. So it's great to be here. Maybe like you, we've spent so many of the months in the last 16 or so months on grids like this, looking at lots of names and faces, but maybe we'll actually meet you in person someday too. So I am gonna give a presentation today and also on Friday that kind of connect together. I was maybe over ambitious about how much I'm going to squeeze in today, so we'll see if I make it or not, and it can spill over a little bit if we need to. Just exactly like we've had in previous presentations, I welcome and encourage interruptions, questions, discussion, etc. I do have 2 monitors, and I am only moderately well equipped to pay attention to both of them. So Ashley, if you, am I sharing the right screen? Can you see the slides? No, I'm sharing the wrong.
Yes, we're on the slides, and I will monitor the chat for you.
Okay, that's weird. This little you're sharing thing moved to a funny place. Okay, it's a little different every time you do it. Great. So this is an MCH epidemiology training course that actually includes lots of other things. And so it's been so great to see all the many tasks and ways and activities that MCH epidemiologists have. My assignment today and Friday is to talk about some really nuts and bolts kind of epidemiology things. And today what I'm going to talk about is measures of association, including absolute and relative measures and measures of impact. Based on the information that you all gave beforehand, I think you span a range in terms of your prior experience. So I'm hoping that I'm capturing a good midpoint in that range. If it feels like I am assuming you know something you don't know, feel free to either say something during the talk or reach out after, and we can have more discussion about it. And hopefully I'm not lowballing too many people either. Some acknowledgements. Some of the slides and content were adapted from great lectures that Mike has given before, and also a nice workshop that Ashley Harai, who you saw give a presentation last week, she used to be Ashley Schempf, she and Jay Kaufman gave. All right, so epidemiology. It feels useful to me when I think about the stuff that I peppered into this talk to talk about what I think epidemiology is. When I was in graduate school, the chair of my department where I was learning said epidemiology attracted him because he thought of it as the intersection of math and biology. And I thought that was kind of interesting, but it also felt pretty incomplete to me because I was interested in more than math and biology. When I think about population health, it's more than those two things. But clearly math and statistics are an important part. Science more broadly, so biomedical science, but also social and environmental sciences are clearly important. And another piece that we don't talk about very much, but is so embedded in the ways that we even understand ourselves as epidemiologists, is actually philosophy. So things like what are normative values and epistemology, or a theory of knowledge, like what does it mean to even know something about population health? Like how do we measure things and is it true? We have rules and guidelines that we use that basically lean on these normative values and epistemology. And so whether you like it or not, for the next little bit of time, I'm going to try and pepper some of those ideas in with the math and science. So my objective today, at a minimum, is to make sure everybody can calculate and interpret these sets of associations. I'm thinking that most of you probably can at the beginning, so I think I'm setting a good minimal line, and we'll certainly cover it. If you're not familiar with those or not comfortable, we'll cover those. But really, ideally, what I'd like everybody to have by the end is to feel somewhat comfortable producing and interpreting epidemiologic measures of association and being critical of your choice or other people's choice of saying what or who is a population, what or who is a good comparison or reference group, and what does it mean when we get a measure of association. So I've really loved the conversations we've had up to now, where we've had discussions about why do we choose this as a reference group versus that, or what does it mean when we do this or that. And I think those are the ideas that I want us to continue to have today. All right, so the work of epidemiology, people think about it in lots of different ways. We can think that our epidemiologic knowledge does descriptive work, descriptive investigations. Maybe we're doing implementation, we're introducing and evaluating programs, and then there's causal investigations, and not everybody is involved in all of these different parts. But we can think of it maybe on a spectrum, where on the left side here is a purely descriptive, I just do surveillance reports, that's all I do, and I love it, and that's really important. On the right-hand side is a strictly causal focus, which I would say, at least at times, also includes things like program evaluation. So it's not just like academic ivory tower stuff, it's also things that that may be done programmatically. And then in the middle, there's times when we do prediction or outbreak investigations or hypothesis generating analyses that's somewhere between those things. So one thing I want to know is kind of where you all are at that. And we've done different things with polls and stuff. I'm going to try and use the screen annotate function. If you haven't used this before, this is just to help you know where. I think on my computer, if you hover at the top of your screen, you should be able to get this bar show up. And there should be a button either that has this pencil that says annotate, or you may need to click the 3 dots that say more and then choose annotate. Hopefully that makes this second bar show up. So let's just do a test to see if this works. Click either the text or the draw or the stamp and try and annotate or mark my slide. All right. Oh yeah, that's great. I love it. Okay, so one thing I'm going to do is I am going to turn off hide names of annotators, not because I don't want to see your names, but it's just as easier to not have the names showing up. Okay, so that's super cool. So that's great. Now I'm going to clear that. Let's see, I have to find my annotation. Okay, stop annotating now because I'm clearing. And then we're going to go to the, okay, so here's what I want. I want you just to use the stamp or the draw tool and mark where on this spectrum you think your work is. Are you in the purely descriptive, hypothesis generating, causal effect? And you can put more than one mark because it may be that you are doing a range of things. I'm kind of curious where you all are. All right. Excellent. So really a nice range of things. Certainly what I would expect, which is a fair bit towards the descriptive surveillance side, but really a good range in there, and certainly some folks doing a lot of program evaluation or other causal effect estimation, and then things in between. So that's wonderful. What that means is the information we're going to talk about in terms of measures of association. They can be used for purely descriptive, but they're often also used in kind of moving this way on the spectrum and thinking about comparing surveillance estimates across years, for example, or in hypothesis generation or in causal effect. And we'll talk about some of the additional tools we need to do this right-hand side on Friday. All right. Thank you for that. Okay, so first, before we get into measures of association, I just want to make sure we're all on the same page. And I actually also want to, introduce some philosophical bents on some things that may seem very simple. So this first piece is just measures of epidemiologic occurrence, right? So when we think about measuring things in epidemiology, we start with kind of the basic nuts and bolts, which is how do we just measure the occurrence of something? And we have a bunch of kinds of measures. I'm not going to go through all these. This slide is here just as a review, but just to say some of the kinds of measures. We have things that are ratios of two numbers. We have things that are proportions. We have things that are rates. And two particular kinds of proportions that we use a lot are the prevalence and the risk. So again, I'm kind of operating under the assumption that you all know these words and they are defined here. We can talk more about nuances of them if you want. There's a couple things I do want to point out. One is that in maternal and child health in particular, I cannot think of many instances, and other faculty may have ideas that I can't think of right now, where we have true rates. A rate implies that we're looking at events over person time at risk. And even though we have the word rate in many of our things, like infant mortality rate or maternal mortality rate, most of those are proportions or ratios. So I just point that out just to be aware. I continue to use the language of rate because it's very common, but I just like to point out that while we can think of rates in many settings, including like all-cause mortality rate is number of deaths over person years at risk, we don't have that very much in MCH. We do have, though, things like ratios, like the maternal mortality rate is also better called maternal mortality ratio, is the number of deaths divided by the number of live births. It's often how it is calculated. Or we have proportions, like the obesity prevalence, the number who are obese divided by the total number, those obese and non-obese. Just as a reminder, again, review, when we're thinking about these measures of frequency and occurrence, we distinguish between prevalence and incidence, and that just has to do with time. Incidence is the occurrence of a new case that didn't exist before. It developed over a specific period of time. And so the risk, for example, is the cumulative incidence. It's the number of brand new cases that didn't exist at the beginning that occurred out of those people who were at risk or susceptible over a fixed time period. So incidence is about new. We deal a lot with surveillance data in prevalence. Certainly if you're using PRAMS or National Survey of Family Growth or National Survey of Children's Health, a lot of those things are prevalence. Okay, so I'm telling you these things because when we talk about epidemiologic measures, we have several key ingredients. Now, this acronym, PICO, is actually often used when we're talking about causal inference, when we're talking about how to develop a research question of etiology. But I actually think it works just as well for a lot of surveillance and descriptive work. And so this acronym, PICO, are the reference 4 kinds of ingredients that we need. We need to have defined a population. We need to have a focal group of interest. If we were talking about etiologic epi, that might be the exposed group or those for whom we intervened on. But if it's disparities work, we might be interested in the group that's at higher risk. Or if it's a time trend, we might be interested in the most recent time period. And then we contrast that with some kind of a comparison or referent group. And then, of course, we have a health outcome. So I'm going to come back to these other two, but in this little review section, I want to delve a little bit into population in particular, and what does population mean? And the reason I want to do that is because those measures of disease occurrence, when we say the risk or the rate or prevalence, those are averages. They're telling us something about the average in a population. And so it seems useful, if we're the ones who are responsible for interpreting these averages, to be clear about who is the population, and does it even mean anything to talk about the average person and their risk of obesity? And what do averages across groups tell us? So just as a little example, I also do a lot with spatial epidemiology and GIS. This is an example from that. Imagine that we wanted to talk about the infant mortality rate, which is a measure of occurrence in the United States. And in 2013, it was 6. And so I just told you that number. Well, that number is true, and yet it also feels like it doesn't tell us the whole story. So imagine that I recognize the whole US is a big group, and maybe we understand that states are important units, that states affect policies, and that the socioeconomic and healthcare environment are different. So maybe we recognize that the population of the whole US isn't adequate. We want to compare the populations across states. So I could produce a picture, a summary of infant mortality rates like this. In this summary, I have organized the rates from high to low, but it's a kind of funny looking picture, isn't it? This is the way that it all goes together if we put those puzzle pieces together. What I think about this is that when we're understanding the population we're studying, the population whose health we're describing, we want to understand how it is in context. We want to put it in relation to other populations, in relation to other experiences. And so this idea of going from like just one number describes them all to describing groups as if they were completely separate from one another, like the previous slide, to this one, where we can understand this measure of occurrence in some sort of context, in this case, geographic context. So just a quick historical note, the origin of the idea of populations when it comes to human and social ideas is attributed to Adolf, I can't say his name, Quetelet or something like that. He was a guy who called himself a social physicist. He wanted to take the tools of physics and astronomy and apply them to people. He thought that when we measure things about people, it's sort of like astronomy, particularly in the 18th century, when they might measure the position of planets from different places, and each telescope was a little bit wrong, but if you took the average of them, there might be a truth to it. So basically, he said the average of a population is like its essence, and everybody else is an error. Well, that's not a very satisfying feeling to have. You know, there be one average man, that was his idea, the average man, and the rest of us are just statistical anomalies scattered around the average. But he was using this metaphor from astronomy. So it leads us to ask, what does it mean when our statistics, like the way many of us are taught statistics, is from this kind of metaphor that if we take an average from a lot of abstracted units, that average tells us something. What does that population mean? Are the populations statistic or substantive entities? Do they actually mean something outside of numbers? Are the populations defined by innate traits or by their relationships? And is there even really such a thing as an average person? What does that mean? I don't know if you guys have ever seen these. This is called a Galt board. They're kind of cool. If you click on this link, you can see a little video of it working. It's basically continues this metaphor of statistics and math and the way our statistical distributions as simply random chance. And what you do is all these little beads, they got poured in the top. And as they go through this little spout, they hit the pegs and they randomly go left or right. And because of the positioning of the pegs, their randomness actually produces something like a Gaussian curve, a normal curve. So it's actually a really elegant, cool mathematical idea. And if you took a statistics class at sometimes, you might have been told that the metaphor we use for statistics is sampling marbles from an urn, like as if we're all a bunch of red or white marbles and you reach in and what's the probability that you pulled a marble out? All right, so what if we're not marbles in an urn? What if we're more than marbles? What if populations are not just statistical entities? So Nancy Krieger, in this really nice paper, which by the way is posted on in this week's section in Teams, and this really nice paper suggested that when we're thinking about populations and health, we should think about our populations in substantive ways, and we should understand our measures in relation to those. So 3 things that were important. One is that populations are bounded, complex entities generated by systemic causal processes. In other words, we didn't just all get thrown down here like marbles. Like, we're created through historical and social and geographic and political process. The populations arise from and are constituted by relationships. So that's not just like our interpersonal or romantic or whatever relationships, but also the relationship between governed and the people, or between entities like corporations or doctors and patients. So populations are related to these relationships, and they are inherently constituted by and simultaneously influence the characteristics of the individuals. So in other words, a population doesn't just determine the people determine the population, and the population influences the people. Now, does that change the math? No, it doesn't change the math, but hopefully what it does is it makes us think a little bit more deeply about what it means when we measure a prevalence of a population. What is their relationship? I'm going to give one example that I use in a few different contexts to maybe try to parse this idea out in an MCH way. This is an adaptation of Jeff Rose's ideas of individual and population health. What I've got plotted here is the distribution of the birth weight of all the babies born in the US in 2017. So you can see along the x-axis here, we've got birth weight in grams, and the y-axis is just how many babies there were. And then the red line is just the marker for that 2,500 gram threshold for low birth weight. And so when we see data like this as a single overall population, we ask questions about the average, but also this idea of why are we different from the average? And so we might ask, what's different between individual babies? It's the causes of cases. Why was this baby born low birth weight? And when we ask that kind of question as epidemiologists, we can come up with study designs and come up with answers like maybe infection or stress or smoking or genetics. Those are things that we have evidence for as predictors of why one baby is on the right-hand side versus the left-hand side of that plot. I have race with a question mark because certainly race statistically is a predictor, but it doesn't exactly tell us quite what we would want to know, which is what is the cause of cases in this question. Now, if I were to show you the exact same data from the US, except I made a separate plot for Black infants and white infants, this is what it would be. So there's a few things that are notable to me about this plot on the right. One is that the two distributions of birth weight to Black infants and white infants are almost identical in shape, right? Most babies are average, there's a few babies heavy, and there's a few babies light. But what we notice is that the entire distribution of babies, of Black infants, is shifted to the left. That shift to the left means more Black infants crossed this threshold of low birth weight, and that's why we have a racial disparity in low birth weight, or that's what produces that statistic, the racial disparity in low birth weight. What I see when I look at something like this is a different kind of question and a different kind of process. And it actually goes back to that metaphor that our statistics are all based on, which is related to the Gault board. So remember, the Gault board was where the marbles go in and they just randomly bounce around and they produce a normal distribution. We could say that variation is caused by randomness, and the randomness is associated with each element, each marble, each person. Some people just randomly decided to smoke and some people didn't. Some people randomly decided to had a genetic factor that made them at risk for low birth weight, and some people didn't. So randomness. In contrast, we can actually think about this metaphor as the idea of structured chance, that there is randomness to individual units, but the structures through which they pass may not all be the same. So variation in this right-hand plot is caused by a combination of individual randomness and group level structure or influence. So if we think about this plot of the distribution of birth weight for Black and white infants, maybe the question is not why was this one baby born low birth weight versus not, and maybe the answer there might be it was their race. Instead, why is the entire distribution of birth weight for Black infants different from what it is for white infants? So that's a question of what differs between populations. So causes of incidence instead of causes of cases. And when we shift the way we, as the people who are producing this evidence, the way we think about asking the question, we suddenly come up with a different set of possible exposures. Like instead of race, Maybe it's racism that explains differences between populations, or stigma and discrimination, segregation, opportunity structures, healthcare access. Just one other quick example that's related to PRAMs. A few years ago, I was on a panel at CSTE with some folks from Wyoming. I know there's some from Wyoming here today who were working on the Wyoming tribal PRAMs. I believe somebody also said in a comment earlier last week, maybe in Montana, that they have a tribal PRAMs. And so I'm going to use the idea of PRAMs to think about how our definition of population matters too. So population-based surveillance, where we understand that idea of PRAMs as sampling from this specific entity, the people who live within the bounds of our geography and had a live birth. So Wyoming tribal PRAMs, and again, I don't know if, I know that it was piloted, that's how I learned about it, but I don't know if it continues or not, was a specific survey designed with a number of criteria. One is you still had to be a resident of Wyoming like PRAMs, but also had to be a mother of a live-born infant, and then also have Native American ancestry. So basically it was a particular survey focused to understand the experience of Indigenous women in Wyoming. Now,
Neva did say, yes, we oversample American Indian mothers and low birth weight from Wyoming.
Wonderful. Okay, good. Thank you for that, Neva. I appreciate it. So now a traditional view of populations would say, well, these are still individual units defined by just kind of a list of attributes, the things that I've got at the top of the slide. And that if we put them all together, we can say that this is the statistical whole. So sometimes when we oversample, we do it so that we can have a reliable statistical whole. But an alternative view is that populations are dynamic beings constituted by relationships, and that meaningful causal public health inference is possible because we can understand something about the forces, the relational forces that made up that population, that made them unique. So one possibility is that American Indian women across tribes share certain aspects of their history and experience in ways that impact health. So their experience was structured and shaped, and their relationships may impact health in ways that are specific to that experience. Also, tribal communities are influenced and defined by their relationships, not only between tribes across the state, but also within tribes and in their relationships with local, state, or federal government. So again, this is just that idea of the simplest starting point we have for measures of occurrence and association is who's our population. And I think we often should be critical and thoughtful about how we define and understand that population. So my take home, epi measures of occurrence, they look like math, and they are math. They're ratios and proportions and so forth. But populations, the things that they are measuring, aren't just stars in the universe measured with error. They're complex entities. And so the most meaningful epi measures require knowledge outside of the math. And so that's the take home from this part. Maybe I could have said that in a lot shorter, I know. Now I'm going to get to the thing that I actually said I was going to do, which is epi measures of association. So we're going to talk mostly about descriptive or kind of maybe semi-analytic epi. We're not really talking about, testing causal relationships today. Just as a reminder, this idea of PICO, this acronym, Population Intervention Group, is intervention or exposed is what the IE is, even though I called it focal group, comparison and health outcome. This is a useful way when we're developing a contrast or a measure of association where we are going to take two numbers and compare them. We want to be able to kind of fill in the blanks under each one of these four things. Who's the population? Who's the focal group? Who's the comparison group? What's the health outcome? So some examples of measures of association are things like the odds ratio, and risk difference. That's in contrast to the risk or the rate or the prevalence, which is the measure of occurrence. Now we're taking two numbers and putting them together to tell an epidemiologic story. I suspect that you all use measures of association, odds ratios, risk differences, impact factors in a number of different ways. I would like you just to spend a moment or two using the annotate tool and the text function to just briefly type, how do you use measures of association, for example, in surveillance, if at all, or in hypothesis generating or predictive work, or in causal or evaluation work. So just take a moment, turn on your annotation, choose the text, and then just click somewhere on the screen and you should be able to type. All right, so certainly when I'm assuming when people under surveillance have race, then they're talking about describing disparities. So quantifying inequalities in health outcomes, determining cause of an outbreak, fact sheets and infographic development, okay. You know, some of you marked that you're doing program evaluation or causal or etiologic work. What are examples of some of the things you're using measures of association there for? Again, risk ratios or risk differences or population attributable fractions or something like that. Okay, comparing different groups, time until follow-up care, association between demographic factors and time spent engaged in intervention, okay. Program effectiveness, good. Maternal mortality and urban status. Excellent. Association between risk factors and outcomes.
There was a question in the chat, which you may get to eventually, Dr. Kramer, but when looking at race, such as Black infant versus white infants, when do you prefer using mother's race versus infant's race in terms of, say, a white mother giving birth to a mixed child?
Yeah, that's a good question. So I think, you know, this goes back to what is the thing we're trying to understand and what's the experience we're trying to measure. If we're looking, for example, at preterm birth, there's a lot of evidence about the experience of discrimination and racism in the occurrence of preterm birth. So in that case, it seems that the race of the mother is the relevant factor. If we were looking at the role of adequate state supervision of child abuse and infant death, postneonatal infant mortality from intentional injury, possibly the infant race would be important because possibly the state is behaving in a different way or the policies act in a different way for a mixed race child than they would in a child that had two white parents or two Black parents. So I think what I'm going to say a lot of times is that it depends, and really the it depends is important because it's not the math that decides what is right. It's what is the question we're trying to ask and what does it mean when we come up with the answer. So hopefully that didn't feel unsatisfying. NSCH only collects the child's race ethnicity, which I find challenging. Okay, that's interesting. Yeah, because the unit of analysis that is selected is the child and then the parent becomes the respondent. I didn't actually know they didn't also ask parents' race. That's interesting. Great. Okay, thank you all so much for that. So I'm just going to clear these. These are excellent, excellent examples, and also point out that these measures of association are not only for causal or etiologic work, that we use them in lots of parts of epidemiology. Okay, so just some, basic mechanics. Let's maybe this is going to be review for some people and maybe new for others. So I don't want to go too fast through it, but I want to make sure I can explain it. This is the ubiquitous 2x2 table that we have in epidemiology. So a 2x2 table, of course, implies that we have an exposure or intervention or something that is binary. So there's a group that's exposed and a group that's unexposed or referent. And we also have a health event that's binary. That doesn't mean epidemiology is stuck in a 2x2 world. We can deal with exposures and outcomes that are continuous. But definitely everything I'm going to talk about today is going to be in our simplistic 2x2 world. One other thing I want to point out is epidemiologists have an annoying way of not agreeing on which way a 2x2 table should be oriented. In other words, should the disease be the columns or should the disease be the rows? So my apologies if this isn't the way you're used to seeing it. It's the way I learned it, where the health event is the rows and the exposure status is the columns. The math works the same no matter what, but you do have to pay attention to which is which. So one measure of association is the risk ratio. In other words, it is what is the risk or the prevalence in one group divided by the risk or the prevalence in another group. And in this table, here's just the simple formulas for how you would do that. And it's going to come out with a number. So in the homework or the kind of pre-assessment assignment that many of you did, thank you for doing that, by the way, we had this example of adverse childhood events measured in the National Survey of Children's Health and the prevalence of overweight and obesity. So here's the 2x2 table where the exposed group are kids who have one or more ACEs, and the unexposed or the referent group are kids with no ACEs. And then the outcome of interest is kids who are either overweight or obese, or those who are normal weight. So if I follow the formula from the previous slide, I would have 100 divided by 264 is the risk of overweight obesity among those with one or more adverse childhood events. And then I contrast that to 71 over 283, which is the risk of overweight, or the prevalence, sorry, it should be prevalence of obesity among children with no ACEs. And those two numbers together give me this risk ratio of 1.51. One way to interpret that, I can't remember if I got I'm going to get to the interpretation more in a minute, but the interpretation is that there is 1.5 times the prevalence of overweight obesity among kids who have one or more ACEs as compared to kids who have no ACEs. I'm going to get to a little bit more nuance in interpretation in a second. Now, a second measure of association. So remember, in the risk ratio or prevalence ratio, we divided the two numbers. The other thing we could do is just subtract them, right? We could do a risk or prevalence difference. And almost all the math is the same, except we're just going to put a minus sign in there. When we do that, we come out with an entirely different number that really means an entirely different thing. It doesn't disagree with the previous number. In other words, when we do the risk difference, we're saying that there's an excess prevalence of overweight obesity of 13% in kids with one or more ACEs compared to kids with zero ACEs. So it agrees in that both of them say having one or more ACEs is bad when it comes to overweight obesity, but it describes it in an entirely different way. And we're going to talk about that some more. I'm going to show you the odds ratio formula because lots of people learn it, and then I'm going to stop talking about the odds ratio. Mike put together a really nice brief lecture and video that you can access on Teams about some reasons why the odds ratio is not our should not be our go-to measure of association. The main reasons are because odds for most people are not intuitive, whereas risk is a little bit more intuitive. So the ratio of two odds is not particularly intuitive. That maybe we can do away with that particular problem in instances where we think the odds ratio and the risk or prevalence ratio are about the same, which is when the occurrence, the outcome of interest is rare. But when the outcome of interest is not rare, as in obesity or overweight, it's quite common, the two disagree, and that becomes a problem. And so I'm going to maybe stop with that and just say we're not going to do more with the odds ratio. Here's the calculation. The odds ratio is 1.82. If you recall, the risk ratio was 1.5. So this makes it look like the association is even stronger. In other words, it's further away from 1. But that's a little misleading because that is in part because this is a common outcome. Okay, so interpretations. So here's the interpretation for each of those three measures. And the main two I want to focus on are the ratio and the difference. Again, with the ratio, we're giving a relative picture. What's the proportionate difference in those, in terms of overweight obesity, in those who were exposed to one or more ACEs compared to those who were not? And so we can either say those with children with one or more ACEs have 1.5 times the prevalence, or we could say it's 50% higher prevalence. If it was 1.2 times, we would say it's 20% higher prevalence. So you kind of get how that's working. So 1.5 times or 50% higher prevalence. In contrast, the prevalence difference is about excess cases or attributable cases. How many additional cases of overweight obesity per 100 children? Because the excess is 0.13 or 13%. So children with one or more ACEs have 13 additional cases of overweight obesity per 100 as compared to children with zero ACEs. There are a lot of reasons why this difference scale is very appealing in applied epidemiology because it's talking much more directly about population impact. But there are still benefits of prevalence ratio, as I'm going to talk about in a little bit. Another way that can help to visualize what the difference is doing is imagining that we're kind of filling up this cylinder This is all the obesity overweight there could be. The maximum is 100%. Let's call the baseline group, those kids with 0 ACEs, the referent group. And 25% is how much overweight obesity they have. So when we're thinking about who's in the referent, we're basically saying, to whom should we compare? Is this kind of the reasonable bar? And we had a lot of good conversation in the PPOR lecture and also last week about who should be the reasonable bar. But then whatever bar we decided as the referent, we're then interested in how much additional risk was accrued by people who had 1 or more ACEs. And the 13% is the size of this extra risk, the risk above and beyond what would have been expected if kids with 1 or more ACEs had the experience of kids with 0 ACEs. A couple odds and ends that I just want to point out. Again, I'm sort of trying to gauge if I'm hitting material that you already know too well and you don't want to see more of it, or that's unfamiliar. So I'm hoping I'm not glossing over anything. But I want to point out a few features of these. One is we want to be aware for any measure of association of what is the null value. In other words, what does it mean? What number would we get if the 2 groups were equal? And in the case of a ratio, either the odds ratio or the risk or prevalence ratio, the null value is 1. So 1.5 is not 1, so it wasn't null, strictly speaking, crisply null. In the case of a risk or prevalence difference, the null value is 0. In other words, if you had 25% risk in one and 25% risk in the other, there's no difference. 25 minus 25 is 0. All right. It's useful also to be aware of which direction, when the risk ratio or risk difference is positive or above the null, or when it's negative or below the null of 1, what does that mean? When it's above the null, so greater than 1 for a ratio, greater than 0 for a difference, that occurs when values of the event are more common in the focal group as compared to the referent group. Like there was more overweight obesity in the kids with 1 or more ACEs. In contrast, we might have an exposure where things look, we sometimes use the word protective, where things look protective. That's where the values of the event are less common in the focal group compared to the referent group. So we would have a negative risk difference or a risk ratio that is between 0 and 1. This is here kind of for future reference if you need it. I'm not going to read through all of this, but there's a feature of differences, which is this section here, and ratios, which sometimes is confusing. And it's important if you are visually representing, if you're plotting, making a graphic of your results, this is important. And the issue is that a ratio is asymmetric. In other words, if we take the risk, a risk has to be between 0 and 1, right? If we take the risk in one group and the risk in the other group and divide them, the smallest it can be is 0. The largest it could be is almost infinity. And we just said that the null was 1. So that means all of the space for protective effects has to squeeze in between 0 and 1, but all of the space for deleterious effects can go from 1 to infinity. It's asymmetric. And that sometimes becomes a problem when people are making plots and they don't think about the scale on their graph. They'll inadvertently make effects perhaps look too small because this really is a lot of space, but we squish it up on a normal number line. In contrast, a difference measure is symmetric. You can go as far up as you can down. Revisiting the reference group. So I've touched on this before, or I've mentioned this several times, this idea that who we choose is important. I wanted to just, based on my memory of discussions that we've had last week and a little bit this week, to just comment on a few different choices of reference groups and recognize that the reason you choose them is important, that they might serve different purposes and they might produce different kinds of meaning. There isn't one reference group that is the right one. It really depends on the particular thing you're wanting to do. So I'm not going to read all of this text, but I'll say some examples of reference groups, and you can come back and look at this later if you're interested. One example is to use a goal or a benchmark. So for example, the healthy people goals we've talked about. So you could take the values in your state or your counties and compare them to that reference group and say, Well, basically, how far is each county or my state from that goal? On the other hand, you could take a population standard. Basically, what is the US average for that particular health outcome? And then you could say, how does my state or my counties or my city compare to that US average? But then particularly for disparities reporting, so disparity measures are measures of inequalities in health outcomes that are unjust. Health equity is the sort of broader philosophical concern with why do disparities exist. But the disparity is the numeric calculation or quantification of the difference. When we think about measuring disparities, for example, in surveillance reports or tracking how we're doing, you could choose, for example, a population that has the best outcomes, like that's the lowest risk or prevalence. That would imply that that is the goal that everybody should be able to achieve. Or in contrast, we might choose the group that's historically experienced the most accrued privilege and health benefits. So that might be non-Hispanic whites in many groups, even though there might be some particular groups that have better outcomes than them. That really brings the focus on what is the magnitude of the difference that is attributable to this accrued privilege and health benefit. So that's just a continuation of conversations I think we've already had richly in previous talks as well. Okay, I've talked fast and hard there. I can't remember if I'm midway, but I want to just pause here. I'm going to take a breath. And also, when I'm looking to the side, I'm looking at the chat. Just see if there's any questions from things we've talked about, which have mostly been the measures of occurrence, the idea of populations, and then sort of the basics of measures of association, the risk difference, risk ratio, and odds ratio. Any questions or comments, clarifications? You, of course, can unmute or chat. All right, I'm going to continue on, which doesn't mean I can't stop again. All right. What I want to do now is dig into some really interesting things that I think happen when we use relative versus absolute measures. And partly it's useful because we make the decision often to use relative or absolute measures, or both, but also because I think it is a nice, it tells a nice story about the importance, the way that value judgments get embedded in math. So I'm going to cover just some basic arithmetic to just remind ourselves again about the difference between ratio and difference measures. So imagine that I have $2 and you have $1. If we took an absolute comparison on an absolute scale, we would say we have a difference of $1. I have $1 more than you. But if we used a relative scale, which is what a ratio does, right? So the risk difference and prevalence difference are on the absolute scale. The ratio is on the relative scale. If you have 2 and I have 1, if we divided that, two things happen. One is the number is 2, so I have twice as much as you relatively. But the other thing that happens is the dollar sign cancels out when we divided. So notice that when we did 2 minus 1, we still have $1, but here we just say I have twice as much as you. The same thing happens in ratios and differences in health. If we take the ratio of two risks, which are represented, say, as percents, the percents cancel out, and we have a number that's unit free. But if we take the difference of two risks, we still have something that's on the risk scale, okay? All right, let's continue. Imagine I have 10 and you have $9. The absolute comparison is I still have $1 more than you in absolute terms. So that's just like the previous story, except in relative terms, now I only have 10% more money than you, not twice as much. In contrast, if I have $10 and you have $5, now in absolute terms, I have $5 more than you, which sounds great. But again, I only have twice as much as you. This is all obvious. You know this because you're working with money all the time. You're thinking about this in our lives. So we understand the absolute and relative. But these differences, the fact that 10 versus 5 is twice as much and 2 versus 1 is twice as much, we sometimes forget that in epidemiology, that a risk ratio of 2 seems really important. But it's important to know, well, where did you start? Did you start with 1 or did you start with 5? Because doubling your money means different things depending on where you started. So I want to tell that story again in the context of the history of infant mortality rates by race in the United States. So this is a plot from historic NCHS data, infant mortality rates for whites and non-whites. I have non-white because in the early part of the century, the way we did racial coding didn't code Black specifically, but we believe that most of the births in that period were in fact African-American moms. And so in a minute, I may switch to language of white and Black, and those do mostly track. Okay, so having said that, look at this. What do you think? How'd we do? Does it look good? It looks like infant mortality went down a lot, for sure. When people ask what made infant mortality go down so much, like it went down a lot. The rates were, here we've got a rate of 34,000 per 100,000 or a rate of 17,000 per 100,000. And it's down here to, we can hardly even see the numbers. It went down a lot. And when people think about what are the causes of that sort of dramatic improvement in public health in the 20th century, it comes back to a lot of really core public health things like clean water and adequate nutrition, vaccine and infection control, access to safe labor and delivery, medical technology and care. All right, so that's cool. What if I showed the same data, except now I'm showing two different measures of disparity? On the left-hand axis, I have the numbers for the rate difference, and the rate difference is plotted in yellow. Okay, so the yellow line is the Black-white rate difference. So this is a time series of racial disparities in infant mortality. On the right-hand axis, I have the rate ratio, and that is plotted in purple. So I've got both of these things here. It seems like we come to different conclusions about infant mortality rate. On the one hand, it looks like we've almost eliminated the Black-white disparity in infant mortality if we look at the rate difference. In other words, it's gotten so small I can hardly even see it. On the other hand, if we look at the rate ratio, it's honestly almost like for 100 years it didn't change. Like, the lowest it is like 1.7, and the highest is like 2.02. Like that's almost exactly the same thing. Like for 100 years, it almost didn't change. So what should we use if they tell us entirely different stories? One says, we're done, we fixed it. One says, you got nothing done, it's not fixed. So the difference says we're making progress saving babies. The ratio says progress is made often by white babies staying just ahead of Black babies, and Black babies are catching up. So the rates are just staying far enough behind that the ratio is staying at 2. So you might ask, well, which one should I do? Well, we wondered about that. We wondered, like, should we only use differences? We say in many places in epidemiology that we prefer difference measures over ratio measures. But are we missing something if we do that? So we did this imperfect analysis of cause-specific infant mortality death across the 20th century. It's imperfect because obviously the documentation about cause of death in infants across the 20th century is incomplete. It's not great, but we do have, NCHS does have data on it. And so this is from that. What I'm plotting here is the racial disparity, not the rates themselves. So the racial disparity, and I'm gonna show you 3 different specific causes of death. First is diarrheal diseases, GI disease. So look at the beginning of the century. There actually was not much of a disparity in infant mortality due to diarrheal diseases in 1920, but something happened and it jumped up to like 7-fold or 6-fold in 1960, and then it went down again. Now, I just showed you a minute ago that all-cause infant mortality stayed pretty even at 2. So this is bizarre, right? This is strange. Well, one thing that happened in there is that's a period of time when we really invested as a country a lot in municipal clean and treated water. And there's really fascinating work done by David Cutler and others that document that the timing of the development of clean and treated water and the neighborhoods that it was delivered to almost always benefited higher income, privileged white communities first. And it was only much later in the century that many low-income rural and Black communities had access. So what happened is the infant mortality from diarrhea declined quickly for whites, and it stayed the same for Blacks. And that produced this really high Black-white disparity, which in time went down because, again, eventually that particular public health intervention diffused across the population. All right, here's another cause of death. This is infant mortality attributable to prematurity. Again, looking in the beginning of the century, this was an important cause of death, but there was not a disparity in it, or not a large disparity. They were relatively similar as causes of infant mortality. But something happened where the magnitude of the disparity climbed steadily and peaked in about 1990. Well, it looks like the development of NICUs, and in particular, the really technological high-intensity management of very low birth weight babies that produced the greatest reductions in infant mortality during this period, those NICUs started off at private or academic facilities where there was not always equal access to care. So to some degree, high intensity, high quality, technologically advanced NICU care was delivered to high-risk white infants before, or communities, before it was delivered, at least equitably, to high-risk Black infants and communities. Now, at this point in time, we know that NICUs are available in lots of urban areas, at least, and increasingly through regionalization, we're working on making sure that that moms and babies in rural areas also have access to the appropriate care. So we do see a little bit of a decline in that. And then the final example is a little less dramatic. It's SIDS. When SIDS first started getting documented, there was a racial disparity, but it seemed like it actually jumped. It climbed a little bit between 1990 and 2000. And interestingly, that's about the timing when AAP initially released their supine sleeping recommendations. And the initial health communication about babies back to sleep was, there are interesting case studies about the language used, who was used in the communication materials, the networks that information was distributed through. Basically, that information got to white families and educated families more quickly than it got to families of color and particularly non-English speaking families. And so it may be that, once again, this new intervention accelerated improvement in the privileged group without a corresponding change in other groups, and that produced this increase in the Black-white disparity. So this whole idea that I'm talking about actually has been described, not specifically to infant mortality, but this underlying idea that the causes of disparities are not just one thing. There's this idea of the fundamental cause, the things that mean that as we come up with a new solution, the people who benefit from the new solution first are usually those with the most resources. And so it's actually the unequal diffusion of progress or access to resources that may be perpetuating the Black-white disparity in infant mortality at about twofold. So back to the question, which do you choose? What do you do when the difference and the ratio tell you entirely different stories? I think both are valid stories, right? They are both true. On the one hand, the total risk and the Black-white risk difference have steadily declined over the past 100 years. And that's because we've done a lot to improve the health of mothers and children. And I think the persistence of the disparity is evidence that with each step of improvement, we consistently repeat the same mistake, which is the uneven dissemination or diffusion of new interventions. So one of the things that it implies to me is, as we develop new interventions programs, how we target them, how we make sure that communities are engaging with them, how we make sure that resources don't become a barrier to accessing them, that becomes the critical point to reduce disparities. It's not just that we need a new program, we need to make sure that the program is available and accessible to populations who will benefit from it most. Okay, so that was a story. It was a story about absolute and relative. And the short and sweet of it is, there are two different ways of measuring association. And while they sometimes do agree, it's definitely possible that they'll tell different stories. If you're producing surveillance reports, you certainly, at least internally, want to be looking at both an absolute and a relative difference. If they agree with one another, you might choose to just pick one for simplicity. If they disagree, though, I think it's really important that you're cautious and thoughtful about what is the story you're telling with the one that you pick, or what is the story you're not telling by excluding one. Of course, one recommendation that many people make is we should report both. This is true in etiologic studies as well. Many people are now recommending that we should not just always rely on the odds ratio and risk ratio, but we should also report, for example, risk differences, because we can sometimes garner additional insight or information by looking at those. Any thoughts or questions about measures of association and relative and absolute? I wonder actually, thinking back to the slide where people annotated what they use measures of association for, and many people included surveillance. I'm curious, do you use differences or ratios, and how do you use them? And if anybody would be willing to unmute and just say how you use them or put it in the chat, that'd be great. I just don't know how you do them, so I'm curious. No one? Okay. We tend to use ratios and not differences, but this is making me think there's value to presenting both. I think there's value in you looking at both. The story that I just told about the patterns in Black-white disparities in infant mortality isn't this, it's not always such a dramatic difference. Same, we usually lean towards ratios rather than differences. I think that is quite common actually, and it's partly about how we train epidemiologists. I think we tend to preference ratios. There's also a benefit if you're comparing things, for example, at using different, you're comparing a set of objects to different referent groups. Maybe you're talking about the rate ratio compared to the previous year or something. With a ratio, you kind of can ignore if there were differences in the starting point. And sometimes that's beneficial. Sometimes you do kind of want to just ignore the baseline and you just want to talk in absolute terms. Like there's a 20% increase in this, but there's a 70% increase in that. Sometimes that talking in relative terms like that is useful. But remembering that, in absolute terms, a 40% increase in something, a rate ratio of 40% in absolute terms might not translate to many actual people because there were very few people having it in the reference group. It was very rare. So I think it does really depend a lot on kind of what does the reference group have going on and how different the story is. I typically only, okay, hold on, let me make my chat a little bigger so I can read that. I typically only do prevalence, but I'd love to start incorporating more, which is why I'm taking this course. Great, wonderful, thanks, Amy. We use difference kind of implicitly in some of our reports when we present the prevalence in different groups and highlight the differences. That's kind of what I would imagine, is that I wouldn't be surprised if you're doing it sometimes in time trends, talking about the absolute change over time, and maybe sometimes comparing across groups. All right, that's great. Thank you all so much. Okay, so measures of impact is actually a continuation of the story we've just been telling in terms of how do we pick. What measures of impact do is go maybe even a little further. So if we think about a rate ratio or a prevalence ratio, we really are interested in the magnitude of effect. An epidemiologist teacher of mine told me there's really only 3 risk ratios that matter. There's the risk ratio of 1, which is null. There's the risk ratio of 2, which is interesting. And there's the risk ratio of 100, which is amazing. And then everything else, it's all going to round out. There's not really much difference between those 3. And I think there's some truth to that, which is that, if we see something of a magnitude, if something doubled risk or increased by 75%, or, if it's a 2.5 or something, like the magnitude of that is really important. So magnitude from a ratio is informative information. But as we've said, what it's missing is information about how common the occurrence was in the referent group. So that's where the difference comes in. The rate difference tells us, well, Was your doubling because you went from 1 to 2 or because you went from 5 to 10, right? 5 to 10 would be a 5% more people got this. The other thing that's going to happen, so that's magnitude, and then how common is the outcome in the referent group. But the third thing that we're going to start to bring in with impact is how prevalent is the exposure. Maybe the exposure is super important, but hardly anybody gets it. And so in a real world, it's not going to make that big a difference. Or the inverse is true, and this is really common in social determinants of health. Maybe the exposure only has a small magnitude of effect, say a rate ratio of 1.2, but the exposure is very common. In other words, whole entire parts of your city are exposed to low access to public transportation or food deserts or whatever the variable might be. So those three things, the magnitude of something matters, how common the outcome is in the referent group, and then how common is the exposure or the intervention of interest. We're going to try and put those together in ways that we can think about measuring impact. I've modified this table a little bit. So in the homework or the pre-assessment that you all did, we had those two examples. One was about overweight, obesity, and ACEs, and the other one was about cause-specific post-neonatal mortality in rural and urban areas. Okay, so the question of interest was focused on why is post-neonatal mortality higher in rural areas as compared to urban areas? In the assignment, we had cause-specific lines. So you were actually trying to evaluate which cause made the most impact. What I'm going to do for the examples I'm going to finish out with here is actually do total post-neonatal mortality. So this is no longer cause-specific. So let me just orient you to this table. It's a little bit different, although it still is oriented with the health outcome as rows and the exposure as columns, just to be sure that I'm clear about that. Now, the reason that I want to just spend a moment pointing to this is that the formulas I'm going to show on the next few slides are all going to refer back to the values that we have on this slide. So use this slide as a reference if you're looking at this again. So if we're talking about post-neonatal mortality, this is the death of infants after 28 days before 365 days among all live births. So we've got total live births and then the count of post-neonatal deaths and the post-neonatal mortality rate, which is not really a rate, it is a proportion, is A1 over N1, okay? And so we can have the rate for the exposed R1 and the rate for the referent group or unexposed R0. And of course, we can have an overall. So these are the numbers. So these exact numbers were not on the homework because, again, this is total. I only gave you, I think, the leading 5 causes of death. So the numbers are a little different here, but the idea is similar. Because the source I drew these from used rates per 100,000, that's how I'm reporting them as well. So 248 post-neonatal deaths per 100,000 live births in rural counties, 166 post-neonatal deaths per 100,000 live births in urban counties. Now, one of the questions that I asked you about on the homework was, would you like any additional information? And wisely, you all suggested a wonderful list of additional information you would like to be able to answer the question well. If you recall, all I gave you were rates. So in other words, all of this information about counts was missing. All I gave you were rates. One of the things I was fishing for, and only a couple people said this, which is totally fine because I asked it in a very open-ended way. One of the things I was fishing for is it's useful to know, well, this looks like a big difference in the rates, but how many babies are actually born in rural counties? Like maybe there were only 20. And if there's only 20, then even if the rate looks really high per 100,000, there aren't actually 100,000 of them. So when we're thinking about measures of impact, again, we want to think about magnitude, but we also want to think about the distribution of absolute deaths and the distribution of kind of exposure in the population. So what we can see from this is that there's a large number, but certainly not a majority of births in rural counties. Okay, so we've got that 248 versus 166. So what? Is this important or not? How important? How do we tell people about it? How do you try and say, oh, there's 248 per 100,000? That's awful. And does somebody agree with you? Particularly if you're talking outside of your office, it may be difficult to kind of communicate this. So that's what we want to talk about a little bit here. There are a bunch of measures of impact. I'm only going to talk about 4 of them. So I'm just going to talk about 4. I could point you towards resources that give you others and discussions about when to use them or when not to use them. I'll also say that for each measure of impact, there's often many different formulas. So I just picked what I find to be kind of the easiest formula, but it doesn't mean it's the only way to calculate it. So if you have like an EPI textbook that has a different formula, that's totally okay. Well, it probably is. It's very plausible that there would be a different formula than some of what I have here. So the 4 measures of impact that I'm going to talk about are the risk difference, which we've already talked about, the absolute number of excess cases. Okay, so that's actually something that we talked about on Monday with PPOR. Something called the percent attributable risk among the exposed, and then the population attributable risk. So these are the formulas, and they kind of build on one another. They're sort of going down the line. The risk difference, as we said, is simply the difference in the perinatal mortality rate, for example, in rural versus urban counties. And the interpretation of this is the excess risk, often people would say attributable to. So sometimes this is also, in addition to being called a risk difference, it's sometimes also called attributable risk, attributable to being exposed or in the focal group. So remember, focal group, the way I'm using that language is that's the exposed group or the intervention group. It's the group that's at the beginning of, it's at the top of the ratio or the beginning of the difference. And that's in contrast, excuse me, to the referent group, whoever you pick as the referent. So the excess risk attributable to. Number of excess cases, we said earlier on Monday, we had that nice conversation about why it can be nice to use excess cases. Like this is how many additional babies died because the health services in rural areas are different from urban areas. So that can be useful. I think it has limits, but it sometimes can help contextualize, like what are we talking about? Something that I've heard used many times is if we have infant mortality or fetal deaths or something like that, people might say, this is how many people fit on a jumbo jet, and this is how many jumbo jets would have to crash every year for us to have this much excess infant mortality. So sometimes things like that can help. And so excess cases, which is this risk difference times the number times the N1 number, which again, looking back at the table, is the total live births who are exposed in the rural county. That is one way to get excess cases. Now, the percent attributable risk among the exposed and the population attributable risk are 2 related ideas. The attributable risk among the exposed is a way to say, well, what proportion of the events in those rural counties could have been avoided if somehow we could make the rural counties have the same rates as the urban counties. So if the answer to that somehow was through regionalization of care, transportation, or improved perinatal quality, collaborative activities, or whatever, through that activity, what proportion could be saved? And so the attributable risk among the exposed is a simple formula. Again, there are many ways to calculate it, but one that I find easy is just to use the rate ratio. So remember, the rate ratio is the perinatal mortality rate in rural divided by the perinatal mortality rate in urban. And if you take that number -1 divided by the rate ratio, it's the percent attributable to exposure. Now, we cannot actually literally interpret it as this is what would happen if we made, if all the rural people moved to urban areas. Because there's lots of other factors that are going on that might not change. So the causal interpretation of attributable risk requires an analysis that takes into account the causal risk ratio. But nonetheless, this can be a very useful benchmark to say what proportion of the total events that happen in the rural areas are due to being in rural versus urban. The population attributable risk has a very similar sounding flavor, except instead of saying what proportion of the neonatal deaths, post-neonatal deaths in rural counties could have been avoided, it says what proportion in our entire state or in the whole region, so in the population at large, could have been avoided. And this is where we actually put in this prevalence of exposure. So I said the measures of impact we're sort of doing, we started with just magnitude, which is something we can get from the basic measures of association. We think about how important is the prevalence of the outcome in the referent group. So the risk difference gets at that a little bit. Some of these others do as well. But then the third thing was, well, how many people actually are exposed? How many people live in rural areas? So the prevalence of exposure. So that's how many births there were in rural areas divided by how many births there were in the state overall. When we incorporate that, we have this new measure, the population attributable risk. What's the proportion of events in the whole population that are due to the health inequalities between rural and urban areas? Or what percent of events could be eliminated if we could eliminate the health differences between rural and urban areas? So if we take those formulas and calculate them, here are the numbers we get. And you can see we're getting different numbers because they're telling us different things, okay? And so the key is to figure out for these measures of impact, what helps me explain to the people that I'm going to be meeting with, or what do I need on my info sheet that's going to explain the burden of this particular exposure or the potential impact of this intervention, for example. So, for example, the risk difference was 82 per 100,000 live births. So the interpretation is there's an excess of 82 deaths per 100,000 live births attributable to infants born in rural versus urban counties. So for every 100,000 live births, there's an additional 82, assuming these distributions stay the same, because of the health differences between rural and urban. How many actual babies is that? Well, that's where we multiply by the number of babies who are in rural areas. So it's approximately 44. So there are 44 additional infants in rural counties who died because of those health differences. So perhaps that's the number or the story that helps communicate what you're doing. In terms of the percent attributable risk, 33% of deaths in rural counties could be attributable to the health differences. So a third of the post-neonatal mortality that happens in rural counties is attributable to the health differences between them. But interestingly, not surprisingly, that translates to only 9% of all the post-neonatal deaths in the population. Why is 9% so much smaller than 33%? Because 33% is talking just about of all the babies who were born in rural areas, what proportion could be are attributable to their rural status. Here we're saying in the entire population, this is how many of the deaths in the entire population are attributable to the rural-urban difference. Another way to see this visually is to recall, was to basically plot these three groups. So this is the post-neonatal mortality rate in rural. Here's the population average, like average across the whole state, and here it is in urban. So I've got this dotted line here at the urban because it's the referent group. Remember, a referent means it's setting the benchmark or the standard. That's why our choice of a reference really matter, because all of these numbers are all going to be how far are these other bars from the benchmark we set. So should the benchmark be the Healthy People 2030 goal? Should it be the geography with the best outcome, which in this particular case was births living in an urban area? Or should it be something else? Thinking about how we set the reference important. Once we set the reference, we can think of this bar in the rural area as telling us how much excess attributable risk is there due to being in the rural environment. In other words, one way of thinking of it is, it doesn't mean that no babies are ever going to die in rural areas. What we would say is we would expect, if all other things were equal, that the mortality rate in rural areas should be the same as it is in the referent group, all things being equal. So all things not being equal, what the attributable risk among the exposed is doing is quantifying what proportion of all these deaths are the ones that are excess above what should have or would have happened if everybody had the same risk. So you can see that this is a much bigger value in contrast to the population attributable risk. Remember, that was only 9%. So this was 30%, 33%, and this was 9%. So that's maybe helpful or maybe not, just another way to visualize that. All right, so, I thought I had way too much stuff and then I talked really fast and now I'm done. So how about that? We're gonna have a little conversation. Some take-home messages. So here was sort of the guiding ideas that I had as I was thinking about this lecture. Math is super important for us as epidemiologists. We count things and we report statistics about things. And so counting accurately, measuring accurately, and doing the statistics right is really important. And so I don't in any way want to undermine the importance of understanding the formulas and the statistics. But how do we make meaning of the math is an entirely different thing. And I think we're not all trained to do that. I feel like this is often an area that we're sort of learning on the job, so to speak. So how do we make inference or make meaning of the math we come up with? So a few things that I've touched on today. Who and how you define populations matter for measures to have meaning. So it may be that you're doing a report where you're interested in all women of reproductive age in your state. You may not have any control over the definition of the population, but there are times when we do make decisions about inclusion or exclusion in our population. And even if you're doing a population-wide analysis, women of reproductive age in the state, or live births to indigenous women in the state of Wyoming, even when you do have kind of a pre-dictated population definition, thinking about that not only as an abstracted statistical entity, but as something that has been constructed through relational and systematic forces over time, and that we can understand why the health in rural areas or urban areas might be different, not just because they're two different numbers, but because of the things that are happening in rural and urban areas. Okay, so that was one point, population thinking. The choice of the focal and the referent group really matter. So one way to think of that is we are making normative judgments when we choose a referent group. We're basically saying, as compared to what? How should it be? The referent group is kind of like, here's what we think it should or could be. So is our choice of the referent a justifiable picture of how it could or should be? Should it be something different? What are the implications of choosing a population average instead of a race-specific referent group? There could be different implications. Sometimes the implication is that it improves our understanding of how multiple racial ethnic groups vary around the population average. On the other hand, sometimes that might also diminish the magnitude of the disparities for some groups and perhaps diminish the importance that other stakeholders see in acting on the disparities. So our choice of focal and referent groups matter. In the case of disparities, we've talked about it a lot, but it also matters in program evaluation, in etiologic research. So if you are doing a program evaluation and you know you have good data on the people exposed to the program, who are you going to compare them to? Who are the people who are the appropriate benchmark or reference for understanding the impact of that program? So the choice of referent matters, not just for the disparity measures, which we've talked about a fair bit, but also for etiologic or evaluation work. Choice of absolute and relative scale matters. In the simplest terms, risk differences and risk ratios are absolute and relative scales, but there's actually relative and absolute issues that come up with regression. So we're going to talk a little bit about we're talking about multivariable analysis on Friday. We'll talk a little bit about regression. And regression can be on the absolute scale or the relative scale. If we're interested in things like interaction or effect measure modification, the absolute or the relative scale matter. So while the story I told of the importance of those, I told from the point of view of surveillance and monitoring kind of health equity, the distinction between absolute and relative becomes important in lots of parts of epidemiology. And then measures of impact, magnitude of association and the prevalence of exposure all matter. They tell us important information about not only what's the relative change in the outcome for people who have the intervention versus don't, but how many actual people did that impact? What would be the consequences if I were to implement this program at a broader scale in my state, for example? All right, so I am going to take it off there, and we do have more time than I thought. So first, I just want to have a check-in again about clarifying questions or comments about measures of association, relative, absolute, measures of impact. And then I have a couple other questions that I might have for you too. Here, I'm going to do something. Let me see if I can do it really fast. Put a new slide up, and I'm going to put a right. I'm going to share screen again. You can. I'm having a little idea. So go with me, but also feel free to make comments while I'm doing this. All right. Once again, I want you to use your annotate tool, and I want you to tell me on a scale from 1 to 10. It's kind of a janky looking scale, I know. On a scale from 1 to 10, 10 being I knew all of this stuff before you opened your mouth, and 1 being I knew none of this stuff before you opened your mouth, kind of where you were with respect to measures of association, measures of occurrence, and impact. I'm asking in part because it's also going to help me maybe better calibrate our Friday lecture. All right. 6-ish. That's great. Thank you. Okay, so what it looks like is kind of in the middle, which is to say a fair bit of this was review and some was new. And while that might or might not be satisfying for you, that feels about where I wanted it to be. For some people, there was certainly a fair bit of new stuff, and maybe for a few people, there was perhaps more review than you wanted. So that's useful. I will keep that in mind too as I think about finalizing slides for Friday. Okay, I'm going to stop sharing that. Okay. All right, good. I'm glad that, yeah, the formulas and interpretations. I tell you what, there are so many possible formulas. And I didn't even tell you how to calculate the standard errors for all these things, but there are standard errors for all these, which means you could put a confidence interval on it, for example. So I'll talk a little bit about standard errors and confidence intervals. I don't know I wonder how much you use in, I can imagine for certain kinds of analyses, p-values, standard errors, and confidence intervals are things you use, but that I imagine probably not so much for infographics or surveillance reports, but correct me if I'm wrong. Do you wish you knew standard errors, or do you use standard errors in the way that you use your measures of association? I'm just trying to pay attention to the chat too. Thank you for the night. Okay, not too much. Report confidence intervals. Okay. Yeah, having more information. We use confidence intervals for mostly everything. All right, great. Yes, I could certainly put some supplemental slides that have those formulas on them. I think everything that I had was also in most epi text, but I'd be glad to just put those together so you have those available. And of course, many times we're doing these in statistical programs that just spit out the formula, spit out the values, and we're not hand calculating standard errors. All right. So I'm seeing, just looking back through comments, ratios and IMR for another birth outcomes. Okay, good. What do you think is the, okay, so now this is a new question. This is a question about measures of association that I have. I know that there's going to be a subsequent talk on health communication to non-epi folks or non-public health folks. But I'm curious what our kind of hive wisdom is about using measures of association for outward facing products. So if you're producing something like a dashboard that's outward facing, or a website, or an infographic, do you get feedback or pushback on interpreting any of the measures you use? I mean, they could be measures of association. They could just be measures of risk and prevalence. People may misinterpret that. And do you have things that you do that you find help circumnavigate those challenges? Anybody have any experiences with either good or bad experiences with reporting epidemiologic measures to non-epidemiologists? I have lots of bad experiences. We usually try to include at least sentence bullet points that explain the racial prevalence because of past confusion from stakeholders. Yeah, that's great, Becky. Agree on odds ratio. Yeah, people are confused when the odds ratio is used. So is that because it's the odds ratio, or is that because it's a ratio? Like, would prevalence ratio or risk ratio be the same, or is it because odds are confusing? Excess cases, so the odds. Yeah, I think odds are confusing. So, when I was in stats, my stats professor said, oh, the best thing about the odds ratio, everybody understands the odds. And all of his examples were gambling examples. I'm like, dude, I totally don't, I don't, when people tell me the odds for a horse to win, I just don't know what they're talking about. So if you're a gambler, then the odds make sense, and then the ratio of two odds makes sense. But if you're not, it doesn't make any sense to me. So
I think there's a reason that casinos use odds.
Yeah, right.
Because they don't want anybody to understand what their chances are.
Absolutely. Okay, somebody, Rami does okay with the odds ratio, but I'd love to hear more from all of why not to use it. So definitely check out Mike's presentation on why not to use it. I think, yeah, I think there's a few reasons. A lot of times it actually isn't gonna, it's gonna give us a very similar or the same answer. So it doesn't become a problem all the time, but there are definitely times when it can lead you astray. And there's hardly ever a reason why to prefer it over a risk ratio or a risk difference. Helpful to have a sentence or slide explaining how to interpret ratios when working. I agree. I often, my dissertation is currently using odds ratio. Well, depends on who's reading your dissertation, doesn't it? That's a decision for your committee. I think definitely in terms of interpreting, having a sentence, I often like to have, here's the number and here's sort of the epi language we use to describe it, and then like here's a lay language way. In particular, I find risk differences and risk ratios can sometimes get confusing. And the reason is, remember when we had that risk ratio of 1.5? Probably the most clear way to interpret it is there's 1.5 times the risk or prevalence in one group versus the other. But it's okay to say a 50% increased risk, except that sounds a lot like the absolute risk difference, which was in that case a 13% increased risk. So then you're like, well, I thought you just said it was 13%. Why is it 50%? And it's because one's relative and one's absolute. If I ever am doing something like that, I'll always put a sentence that says, in other words, that means that for every 100 children, there'd be this, or the proportion of kids with one or more ACEs is 50% higher than than not. So anyways, when do you think we should use odds ratio versus risk ratio and measures of association? The only time that it, okay, so hold on, there's a UPS guy at the front door. I'm gonna run really quick. I'll be right back, okay? Okay.
So I can, oh, okay, go ahead.
No, go ahead.
I was gonna say, while you're gone, I can talk about that
Talk about it, yes, good.
for just a moment. So I think that the odds ratio is useful, as you said, Michael, when it's a good approximation of the risk ratio, because people, when they hear it and you say, the odds of having this outcome is 1.5 times higher in the exposed group compared to the non-exposed group. When people hear that, they think in terms of risk, right? That's the way that people understand it. So as long as it's okay for them to make that mental shortcut, then the odds ratio is fine, right? But if it, like the example that you had in your slides where it was 1.8 compared to 1.5, I would not use the odds ratio, because people are going to think that the risk is 1.5 times higher.
Correct. And that's where I think some additional language to interpret really helps.
Yeah.
I was just going to chime in. A lot of times where you see odds ratios used to estimate or as like a measure of risk is in like congenital defect studies or birth defect studies, where you have these outcomes that are super rare, and there's some sort of like complex case control study used to identify risk factors. And a lot of times that's an example, I guess, of like a appropriate analysis to use the odds ratio for.
That's, yeah, thanks, Jake. That's really great. So that would be, I mean, the one thing that I feel like is the most common reason where people really should or have to use the odds ratio is for a case control study. Certain kinds of case control studies, you can do some correction factors and come up with a risk ratio, but mostly the whole nature of case control means that you need to use the odds ratio. You can't use a risk ratio because you don't actually know the risk in the baseline group. So the case control studies for congenital anomalies is a great example. Another kind of dumb and practical reason is because the statistical processes that estimate risk ratios or risk differences rather than odds ratios don't always converge. So the model, so in SAS, for example, it's proc logistic to do a logistic regression, but you could do like proc gen mod and fit a log binomial model to get a risk ratio. But it is definitely possible that the logistic model will converge. In other words, it will give you an answer that's statistically valid, and the log binomial will not converge for a bunch of confusing statsy kind of reasons. So sometimes I've been stuck using an odds ratio just because I can't get the damn thing to work any other way. So that's not a very good reason, but it happens. Yeah, Neva says, Jake, this is what our epi teacher told us to do, use odds ratio for case control. Yeah. And again, in terms of when does the odds ratio reasonably approximate the risk ratio? It is when the outcome is rare, which as a rule of thumb, the prevalence of the outcome is less than 10%. So overweight obesity, that definitely doesn't work, but like very preterm or very low birth weight babies or infant mortality, that's statistically rare. And so an odds ratio would work. I don't know, there are also some kind of things about something called collapsibility, but I'm not going to talk about that now, but that's just another problem that the odds ratio has. All right, any other questions? I appreciate those who kind of contributed on challenges and opportunities for communicating these things.
I just had a quick question, comment. A lot of the reason, or I guess the main deterrent for me to not calculate absolute measures is I'm just not is proficient in programming those types of analyses in SAS and interpreting the output. So if I'm on a time frame or whatever, and I'm trying to create an estimate, I'm just like, well, I know how to calculate a risk ratio and interpret what SAS spews out at me.
Yeah.
So if there are just any, if you got, Mike, I'm not sure if you shared like sample code in that list that you sent out, or just like a place to interpret output that the computer gives you if you're using a statistical analysis package. Could be super helpful.
Absolutely. No, that's great. I think, Mike, you can correct me if I'm wrong. I think in that code that Mike posted, there is, so the thing you would do to most directly calculate a risk difference would be to do a binomial identity model. So you do ProcGenMod, and the family is binomial because the outcome is binomial. And identity means don't do a log or logit transformation, just leave it. And then the beta coefficients are literally the risk difference. So Mike, I think I saw that in there, right? You have some code for that?
Yeah, so there is code for that in there. There's not, there are not interpretations in that document, but and that's something that we talk a lot about in the MCH EPI training course in even numbered years.
Mm-hmm.
So, hopefully so two things. One, if you want to hear about that, all of the sessions from last year, because we were virtual, are recorded. And so you can find those on the CityMatch website. So, you can check out those discussions. And then we'll be talking about that stuff again next year. So it'll take a little bit of time for me to walk through, I think, in an understandable way, how to do that and interpret it correctly. But there is some code provided. If you want more information, I would love to talk to you about it. So anybody reach out to me. I'll probably talk to you about it longer than you want me to. So be prepared for that.
Take Mike up on that. That's a great opportunity. I think all of us would be happy to talk, but I think, yeah, the best way to learn how to do it is to have an example and say, here's what I want to do. Here's what the variables are called. What do I try? So thanks, Jake.
There was another question in the chat if you have time.
Sure. I work with breast and cervical cancer screening programs. Can you give examples where we can use risk difference or excess cases with screening? Yeah, I mean, certainly you could talk. So it depends on what data you have, right? You could talk about risk differences or excess cases of screened versus unscreened, or differences in terms of stage at diagnosis. I mean, it depends on if you've got cancer registry data, or if you're linking to the National Death Index, or kind of what sorts of things the outcomes are. But if you have a focal group that you're interested in and a referent group, and that could be time, comparing two time periods, it could be geography, comparing rural urban, could be groups comparing race, ethnic, or socioeconomic, or it could be an intervention, like we piloted this mobile screening mammogram van for these places, and we'd like to do kind of a pre-post. All of those are examples of a focal group, like the time period or the group or the geography or the mobile van, and a referent group, like a different time period, a different group, a different geography, or before the referent van, or the place that didn't get the mobile van. So if you can think of anything that you typically do with your data where you have an interest in understanding, does one group have a different outcome than another, then I think the RD or the excess cases could work. So I don't know if that is specific, or maybe that's too vague still. But I do think there was a lot of opportunity to use it in cancer surveillance and screening. All right, that's all I've got. I'll hand it back to Mike and Ashley. Oh, actually, let me say one more thing about Friday. Okay, so Friday, we're going to talk about multivariable analysis, which is going to include a little bit of regression, a little bit of stratified analysis. We're also going to talk some about bias. And one way that I find useful to do that is to use this tool that's gets thrown around a lot now, and I think is useful to learn early on, and it's called directed acyclic graphs, or DAGs. I posted a little intro video to DAGs on Teams. It's about a half-hour long. It may feel a little like I'm speaking another language. I think if you were able to listen to it before Friday, it would help. But if you didn't, it's not the end of the world. You could listen to it after Friday. But I just want you to know that that's there. You do not have to understand everything about it, but once you kind of get used to it, it's really a powerful tool as we kind of shift on that spectrum away from descriptive. Anytime we start to adjust for variables, whether we think we're doing it or not, we're probably entering a causal world, and we should start thinking causally. And so that's what DAGs are good for. So anyways, that's just to say that that is posted. Okay, now I'll stop.
Thank you. I just want to say thank you, and thanks to everyone joining us. You'll have emails from me as to be expected. So I'll hand it over to Mike to close out.
No, and just thank you, Michael, for taking the time to talk to us about this. As you mentioned, on Friday, we'll be talking more epi and statistical methods. Then next week on Monday, we'll be talking evaluation, right? And so Pat is going to be talking to us about evaluation, and she just has so much experience there. Next Wednesday, communication with non-academic audiences, and then next Friday is the panel session on social determinants of health. So I think we have a lot of exciting stuff coming up. Some of it more stats analysis heavy, some of it more, I think, just useful for thinking about how to be a good epidemiologist. So we're trying to get a good mix of those types of things, and please let us know how we're doing, and let us know if this stuff is valuable and helpful to you in your careers, because that's why we're here. All right, thanks everybody.